organizers of this meeting for asking me to come to the webinar to talk about, amongst other things, Eructos, aerofagia, hipo, rumiación. And my most important message is that these four symptoms are completely different things. They are four different cups of tea. And most patients and many doctors mix them up, and that is something that should be avoided. So this is the most important take-home message. Starting with Eructos. The classical belching is, of course, the venting of material that is in the stomach, and this can be swallowed air or CO2. For this to happen, the lower esophageal sphincter must open, and for this, the creator or evolution has designed a transient LAS relaxation, which is a reflex that is initiated by distension of the proximal stomach, and then via these nuclei in the brainstem, the information comes back via the vagus that lets the sphincter and the caudal diaphragm relax. The intraluminal impedance measurement has made it possible to study the flow of air through the esophagus, and this is a classical belch seen with impedance measurement. You see a rise in impedance that goes very rapidly up to the upper end. The opposite, of course, is an air swallow, where you see the swallow pushes down the air in the abnormal direction. Now, when a patient complains of excessive belching, the doctor usually thinks this is aerophagia, and that is usually wrong. I have a video here of a patient with excessive belching. Can you press on it, or should I do that? Can you start the video? Shall I do it? Try. Okay. Just click on the screen, on the black thing in the middle. Yeah, here's something. Can we see the screen? Yeah. So this is a patient, she is saying that she has a lot of belching, especially when she lies flat on the left side. Can we have the sound a bit more? And they did, of course, the colonoscopic desufflation, and they found no obstruction, no volvulus, but he was dismissed home with more laxative, but he repeated the thing. He came every now and then with this. And then he was intensively studied with CTs, etc., difficography, manometry, electrobiopsies, and even an antiduodenal manometer, which will show nothing. And we fear that his colon had to be removed because we fear that he would someday he would have a lower. But then we did a 24-hour esophageal impedance monitoring and found that he was excessively airy during the days, during daytime, but not during the night. And in closer study, it was massive aerophagia. It's difficult to see. And we sent him to our speech pathologist, and although it was not completely normal image afterwards, he no longer needed urgent colonoscopic intervention, and he certainly didn't need a colectomy. Those are rare instances where you have a combination of constipation and massive aerophagia it can lead to these dramatic pictures. Hipo. Hipo is a very complex thing also, but it's something totally different. It is a vigorous contraction of the respiratory muscle, the diaphragm, the intercostal muscles, and the scalene muscles, and at the same time a closure of the glottis. This is all via different nerves, and there is a center in the brain to have these hiccups. If you would like to measure them in the laboratory, you could do manometry. In this case, in the lower signals, you see the esophageal signal and the gastric signal, and you see that the pressure goes down in the esophagus and up in the stomach quite regularly, and it's very sharp, well-defined pressure variations. If you do at the same time impedance measurement in the esophageal body, you will not see anything, because there's no air going through the esophagus. The air tries to get into the airways, but it is not going through the esophagus. So impedance measurement doesn't help you in hiccups. Can we start this movie also? The interesting question, of course, is why do people hiccup? I mean, we can understand why we belch, we can understand why we do sneeze, but hiccups. And every pregnant mother will tell you that her child hiccups every now and then. All mammals hiccup, so there must be a reason for this. This is not created in evolution for nothing. And nobody knows the answer to the question. But I think the most plausible theory is that it is a method to train the breathing muscles, the respiratory muscles, whilst in utero. Because when you're out, you immediately have to use them. So you have to be strong. That's the theory. As you all know, there are many treatment options for hiccups. And as always, if there are many options, none of them is very good. This list is non-pharmacological treatment options. Some of them you can try at home, but others, for instance, carotid massage, I would not do at home. And others are of dubious efficacy. And there are drugs which can all be tried in desperate cases. Baclofen now is the most preferred, but it doesn't work in all patients. Now another movie, this is the last one, I think. This is from the Australian television video here. I just found it.
Now, we've all heard the old wives' tale about how you combat hiccups. Some try jogging upside down, others suggest...
They have a teenager who has frequent hiccups. And she made it to the Australian television network because it's so interesting. No doctor knew what to do about it, and it was incurable.
It's a familiar sound to the family and friends of 17-year-old Melissa Krantz. It was more than 2 years ago when Melissa first noticed she had the hiccups every day.
I roughly hiccup around 80 to 100 times a day. There's no particular time of day, they're kind of just scattered. It doesn't really matter what I'm doing.
Notice that she first finishes her sentence and then does the hiccup. Whereas a real hiccup,
it's really funny at first, but now I think they're just used to it.
Hiccups in the middle of a word, because it's an involuntary control. But this is somebody who has this tick or whatever. Probably she wants some attention, and she now has the attention. I don't know how to treat it. Next, yeah. So this is not a hiccup. And by looking at the patient, you can see that. But most patients will tell they are hiccuping, but they may have a supragastric belching. If you have the chance to see them, or have them make a movie with their iPhone, then you know what they do. Oh, sorry again. This is a case of a 17-year-old girl who, it was a couple of years, had intracranial hypertension, and for this she needed a lumboperitoneal drain, and it had to be revised every now and then, and since the last revision she had debilitating hiccuping. Everybody thought it was hiccuping. and it interfered with normal activities such as eating, and no explanation was found. And when we did the 24-hour pH impedance study, you can see that there was a lot of air moving around during the day, but not during the night. And in close up, it was excessive supragastric belching. And as you will may guess, she was sent to the speech pathologist after explanation, and she and her mother accepted our explanation, and she was cured. This was a miracle cure. She stopped doing it and resumed her life. Now, rumiación, the last of the four. That is also something different. It is a syndrome that has different descriptions in infants and adolescents, but it is characterized by repetitive regurgitation of recently ingested food after meals. And you can chew it out. I mean, you can spit it out, or re-chew it and then swallow it again. It is not preceded by retching. There is usually no nausea. This is what it looks like during a ambulatory impedance pH pressure recording. Lower 3 channels are pressure. And you notice that there are several reflux regurgitation episodes, 4 of them, and all 4 of them are preceded by a spike in pressure in the stomach. This is the mechanism of rumiación. Patients squeeze their gastric contents in the esophagus and above. This is with high resolution manometry. You see the same phenomenon. The yellow pillar is the high pressure, and you see the resulting regurgitation. We sort of think that 30 millimeters of mercury is the minimum amplitude of gastric leak that you need to do the rumination. And in addition to the primary rumination that I showed you in the previous slides, there is also a variant where people start doing the pressure increase when they feel that there is something in the esophagus. So they reflux first normally, spontaneously, and then squeeze it out. That's secondary rumination. It has been described that you can do diaphragmatic breathing for the rumination syndrome. And the trick is that they have to use the abdominal muscles to do the breathing. And that prevents them from using the abdominal muscles for squeezing liquid out. And this has been shown to be effective. And a recent study from Barcelona, of which we'll hear more in the next symposium, I presume, has done it with biofeedback with electromyography of the abdominal and thoracic muscles. There is this paper of 5 patients who were treated successfully surgically for rumination, but I wouldn't believe it immediately because they didn't do any measurements and there was a short follow-up, and I'm a bit skeptical about it. The take-home messages then are that belching, aerophagia, hiccups and rumination are 3 or 4 completely different things. Belching is of 2 types, gastric and supragastric belching, and if you see a patient with excessive belching, it's almost always supragastric. Aerophagia should not be used as a synonym for belching. Cardinal signs are abdominal and intestinal distension, not belching so much. Hiccups are unpronouncedly repetitive contractions of the respiratory muscles, and rumination is postprandial regurgitation that should not be confused with vomiting or reflux. You can diagnose belching with impedance monitoring, as you can aerophagia. For hiccups, you would need pressure monitoring. And for rumination, you need a combination of impedance and pressure monitoring. 3 of these entities can be unlearned, but hiccups you cannot unlearn. I thank you very much for your attention. I invite you all to come to Amsterdam next year.